Okay, good afternoon again, ladies and gentlemen. We'd like to start the final session, Partnership Roundtable. As we get closer, we get tired, but I think this is going to be a very fascinating session, and I'm very happy to be working as a moderator for this important session. I'm Hiroshi Kato, Vice President of the Japan International Cooperation Agency, and the director of the JICA Research Institute. Before we invite the panelists to make their presentations, I'd like to clarify the objective of this final Partnership Roundtable. As we recall, we started today's conference by hearing the messages of very strong commitment by the government of Japan, the World Bank, and WHO. And then in the subsequent session, we learned from the experiences of Japan and 10 other countries, both through the Japan World Bank joint study and also through the ministerial presentations by the representatives of countries made by the ministerial representatives. And in the last session, we talked about the measurement and monitoring, and we learned the new proposal according to which the indicators will center on health service coverage and financial risk protection coverage. I think indicators, defining indicators is akin to operationally define what universal health coverage is. So we're now entering to a very in a field where a very concrete discussion is possible. Now, ladies and gentlemen, the objective of this final policy development partnership roundtable is to hear from various development partners what they think about universal health coverage. We asked them three fundamental questions. First, they are expected to make presentations on what kind of approaches they are taking toward universal health coverage. And number two, what kind of lessons they have learned from today's discussions. And perhaps thirdly, what kind of collaborations they envisage with the organizers of this conference, the World Bank and the government of Japan, toward achieving universal health coverage. And for this purpose, we have a very excellent set of panelists comprising representatives of development partners of various sorts. We have bilateral countries and agencies, regional banks, and specialized agencies, and civil society organizations. Each panelist will make a presentation which we understood is going to be 5 minutes long, but since we are a little behind schedule, it'll be appreciated if you kindly shorten your presentation a little bit, and maybe in 4 minutes. And after that, well, I'd like to have an open discussion with the floor, and definitely we have to finish the whole discussion by 5 o'clock, so I'd like to solicit your collaboration in that regard. Now, without further ado, I'd like to invite the first panelist, maybe in this order, and after we have gone to that end, maybe we'll start this end. So we'd like to start the representative of the Ministry of Foreign Affairs of France to make a presentation.
Thank you, and I want to thank the Japanese government for organizing this event and for allowing me to speak. I'm the French ambassador for the fight against HIV and communicable diseases. And given the fact that there are very good interpreters, I'm going to speak French. So thank you once again for Japan and the World Bank to organize this meeting. Je voudrais faire quelques remarques.
Allow me to make a few comments, and I promise to be brief because we were requested to be brief. Several points have been raised, during the course of today as well as yesterday. Yesterday, I was participating in the Global Fund-related conference. I would like to raise 3 points. France is strongly committed to UHC, and we are strongly committed to the inclusion of UHC in the post-2015 agenda. We very much appreciate that the World Bank Group is committed to that end. And we also evaluate highly that the indicators are simple. They have to be politically feasible as well. In the previous session, the indicators had been taken up, and quality was an issue raised. We have to properly consider quality as a dimension. As we endeavor to improve the health system and to upgrade the skill levels of health workers. In order to meet that end, international cooperation, which is already achieved in the area of health, will also have to be made more robust in communicable diseases as well as the health system. We will have to step up the level of international cooperation which already exists in various areas. In addition to the conventional cooperation, international cooperation must be further promoted. The next point is something we must be quite attentive of. Countries are trying to achieve UHC through persuasion, and we must support countries that are trying to adopt UHC as we proceed towards the 2020 goal. These are politically ambitious targets, but there's much uncertainty as to whether these are achievable targets. In France, historically, it was only France amongst the members of the civil society that advocated the necessity to support the southern nations towards HIV response. That was a social mission, and we were able to do that by collecting funds. $1.2 billion were mobilized in Washington, and Japan has made a significant contribution. And thanks to such support, we were able to respond to the fight against HIV, which is one good example. There are friends from IMF in this room, but poverty, there are friends from the Global Fund, but tuberculosis is another disease dealt by the Global Fund. And this is a disease that is still prevalent in several countries. And multi-drug resistance of tuberculosis is becoming very serious, which has proven to be quite costly for the health system. How can we cover the necessary treatment for such tuberculosis? This is a serious problem. And this is yet another issue that we need to concurrently think about. Actions are being taken by the Global Fund, and those activities also will have to be captured in the framework of the UHC. There's one other point that I wish to mention, and that is the necessity to support the poorest of the poor. Of course, measures to support the poor must be afforded, and first and foremost, UHC for those cohorts would be necessary as they try to depart from poverty, which is not an easy task. Expertise is necessary. G-Buster is an organization that exists in France, which is based upon coalition and solidarity. And this is an organization that implements health-related initiatives in Sahel. Infants below 5 years of age are the target for health services, and in 3 years, 30 million euros would be spent for this initiative. Another point that is necessary is innovative finance, especially for the Sahel region. France has already introduced innovative financing, for example, air ticket levying or financial transaction levying. These are some of the suggestions presented by France, and those are some of the innovative financials necessary.
Our next presenter is Dr. Bharat Edis from the Asian Development Bank. You have the floor.
Thank you very much, and thank you also to the Government of Japan and to the World Bank for organizing this very important and timely meeting on a topic that is receiving increasing attention. It is well due. The Asian Development Bank has a long-term strategic framework that sets forth its directions of support to its developing member countries. This strategy, Strategy 2020, as we call it, recognizes the role that health plays in advancing inclusive growth. Following the adoption of that strategy in 2008, we adopted a more specific operational plan for health, which emphasizes health system governance as well as public expenditure management, which are key elements in achieving universal health coverage. The health operational plan also stresses partnerships, and looking forward, we intend to continue and expand on our collaboration with the WHO, with other development agencies and partners, including working on knowledge products to share experiences around the Asia-Pacific region and globally. And this conference, I believe, showcases powerful potential of that experience sharing to inform reform efforts in the health area. We've seen the Asian economic miracle sharply reduce the incidence of poverty and other deprivation in the region, yet still 700+ million people live in chronic poverty in the developing parts of this continent. And we also see that there are major challenges in trying to achieve good health outcomes. There are, as has been noted, high levels of out-of-pocket payments. There are large gaps in public sector finance and in service delivery. There is under-regulated and poor quality goods and service in the private health sector. Improving health sector governance and financing will improve value for money. In terms of ADB's portfolio and how we're contributing to health, in terms of the projects that we're financing in our developing member countries, there's mainly two areas where we're working. One is to expand health coverage to marginalized and unreached populations, and secondly, to improve services and efficiency through publicly delivered services as well as through public-private partnerships. Just by way of example, in terms of expanding coverage, we're supporting urban primary health care in 10 municipalities in Bangladesh, rural primary health services in 8 districts of Papua New Guinea, and a new project is providing support to primary health care in the highlands of Vietnam. These are just some examples. And more recently in Pakistan, last month, we approved substantial financing for the scaling up of the existing conditional cash transfer program in that country, and part of that project supports a pilot social health insurance program that will reach another 750,000 people within the next 5 years. In terms of improving health services, some examples of the areas where we work include the hospital sector in Mongolia, as well as human resources development for health in Vietnam. We are increasing our dialogue around systems supporting universal health coverage. For example, in health coverage in Laos, aiming to improve finance efficiency and equity. And we're also working in public sector management in countries like India, Indonesia, and the Pacific to improve fiscal balance and population coverage of social health insurance schemes. So for next year, 2014, we're looking at developing our knowledge base on social health insurance and in health finance. We'll be partnering with other agencies and partners and governments, including many in this room. We're building on the experience in other sectors where ADB has been active, like infrastructure, for example, in the area of public-private partnerships, how those might be expanded further in the social sectors. We plan to consolidate this knowledge next year through a series of country reviews, and we will be seeking collaboration with other agencies in this. I just mentioned quickly that ADB is in the process of reviewing its long-term strategy, which, as I mentioned, does recognize a specific role for health, and the expectation is that there will be a renewed and increased emphasis on health. So I expect that ADB's contribution to this agenda will actually pick up from this point. Just in terms of 2 or 3 lessons that I've identified in this conference, and there were quite a few, actually. First and foremost, Japan shows that political commitment to leadership and a path of constant improvement can lead to efficient, effective, affordable implementation of good social policy, even in a complicated, expensive area like health. Clearly, common measures for universal coverage are needed for national goal setting, measuring gaps, and comparing health systems' effectiveness and efficiency. Good indicators are also needed to determine the depth and social protection value of health systems access, especially by the poor, and that was highlighted in the last session. New information technologies, something we probably didn't talk about enough, and tools provide opportunities for successful low transaction cost coverage in informally employed and other difficult to reach populations. And finally, there is a need for multiple actors to address health system issues within this common framework of universal health coverage. And I can assure you that ADB will be taking an active role in helping to advance that agenda here in Asia and the Pacific. Thank you very much.
Now we have had 2 presentations, one from a bilateral donor country representative and another by a regional multinational funding agency. And now we turn to the presentation of Mr. Stefan Nashuk of the Rockefeller Foundation. Now you have the floor.
Okay, thank you very much, and good afternoon. Near the end of the afternoon, in fact. So I'd like to also just thank the government of Japan and the World Bank for convening this important meeting. This has been, I think, really, really good and very useful, certainly for me, and hopefully for others here. The Rockefeller Foundation has been working on UHC through our Transforming Health Systems initiative since 2007. UHC became an explicit objective of this initiative around 2008, so we've been sort of beavering away and working at this for about 6 years now. So coming to this meeting is, for me, actually a very affirming and good experience, honestly. A lot of what we do has actually been said in this meeting, so I don't actually need to take a lot of time. I'll take a little more time with a question. We're doing 2 things, I'd say, 2 core things on building the enabling environment for UHC. One is trying to embed UHC as a post-2015 objective, and that was discussed this morning. Jim Kim mentioned this in his speech. We think that that's very, very important, and that sort of creates a lot of other good things. We're also supporting WHO and the World Bank for what I'd call the last session, which is developing a framework for monitoring progress towards UHC. So that I would call sort of the throwing the stick down the road approach. And creating kind of common metrics. I think that's also going to be a very important and unifying approach to driving much more productive action, both among the donor community and within countries. Finally, we're working on sort of what I would call developing networks and interventions regarding the how-to of UHC. This is where it gets a little murkier. There's a big gap between committing to UHC at a political level and successfully implementing it within countries. That's not new news, but it's relevant news. So we're doing a few things. We're doing direct work on supporting technical interventions regarding UHC, really only in 3 countries that have the politics right, as it were. Ghana, Rwanda, and Vietnam all have very strong political commitments towards UHC, and we've been engaging there for about 5 years. In addition, we're working on something that was mentioned this morning. We've facilitated and funded in collaboration with the Bill and Melinda Gates Foundation, DFID India, and through a lot of sweat equity of the World Bank, the Joint Learning Network for Universal Coverage, which is a 9-country network that focuses on technical areas chosen by countries, which is very much the how-to of UHC, which is where things tend to often break down. Those 5 technical areas are provider payment, quality, information technology, primary care, expanding coverage. These topics were chosen by countries as being priorities and being chosen as topics that were priorities in the sense that there are common problems shared across groups of countries. I would just mention around this very briefly, and then I'll move on, that the reason we've focused on joint learning is that probably 3 factors. One is that a lot of lower and middle income countries have made significant progress in achieving UHC already, and there's already embedded capacity, but this capacity is not systematically shared or leveraged. The fact that many technical challenges have common elements across countries. Working together, countries can do more together than they can on their own, and there's a lot of saved costs in terms of time and effort. And frankly, at least in my opinion, the fact that donor and technical agencies can support or facilitate UHC uptake in countries, but they can neither drive it nor can they wholly finance it. In fact, donor financing in most countries for health systems or UHC is a very, very small proportion of what countries are spending. Most of it is coming either from out-of-pocket payments or from tax revenues within countries. And I think we need to be cognizant of that fact and act with the appropriate humility. In terms of key messages, so just in terms of future collaboration first, very briefly, basically it's pretty simple. We'll continue to work on the development of UHC measures and support that as much as we can. And we are trying to engage in more partnerships around the Joint Learning Network, both in terms of more countries and more partners. And we actually had an informal meeting with JICA and the Ministry of Foreign Affairs yesterday evening about this as well. So I think we take that as good news. In terms of a takeaway, I think that there's one very interesting kind of issue that's emerged for me here, which is the sort of the nexus or the tension between politics and policy. And what I mean by that is we've heard a number of examples of what I would call suboptimal policy raised in this meeting. For example, voluntary enrollment and requiring premiums from informal workers. Some countries may be trying that. Or rolling out a UHC program by only starting with the formal sector and trying to figure out how you'll get to other people later on. And then there was a lot of pushback among other people in this room saying, well, that's actually not best practice, and we've learned a lot of things saying that that may be not the best way to approach this. So that's an interesting question to me, and the reason is because we acknowledge that politics matter, and yet as soon as we get to a technical question, we forget that politics matter. So what I mean by that is, do we know in each of these instances, are countries not following normative best practice because they don't know what their options are? In other words, they don't have technically enough capacity to know what their choices are and they don't know what to do. Or they actually have a reasonably good idea of what their choices are, but they're choosing the most feasible path given a set of institutional and political constraints within each country. Or maybe other reasons. See, understanding the difference between not knowing and knowing and choosing a path because it's an approach that is feasible within your setting implies a very different set of donor and institutional relationships and partnerships between donors and countries. And I fear that sometimes we assume that away a little bit too much. So what I would hope is that as we take this UHC ship forward, that we also try to think much harder on a country-by-country basis, what is the link between politics and policy? What are the symptoms of the disease? And what are the best treatments? And we have to work within what countries can realistically do, not only what is the normatively best policy. So I'll stop there. Thank you very much.
Thank you very much. Now we turn to the presentations by specialized agencies and organizations on health and population and other related areas. So we have 4 presentations of the organizations that belong to that category. We'd like to first invite Dr. Osamu Kuni to make a presentation on behalf of the Global Fund for AIDS and tuberculosis and malaria.
Thank you, Chair. First, I want to begin with my sincere thanks to Government of Japan and the World Bank for inviting the Global Fund for this very critical, important conference. Well, okay, there are three questions. First question is what the Global Fund is contributing to this UHC. I can say three maybe the points and aspect. One is a partnership. Actually, as you know, the Global Fund is the 21st century model of a partnership, and partnership is kind of a founding principle of a Global Fund. But the partnership should be very specific and strategic, because everyone knows that the importance of a partnership, but the real importance is a very strategic partnership, especially for investing for the impact and value for money. And we created kind of the CCM, the country coordination mechanism. So building kind of the mechanisms for partnerships is very important. And for example, that in Myanmar, that the Global Fund CCM, country coordination mechanism, become that health sector coordination mechanism. So, kind of facilitating coordination, etc., very important. And today's topic, this title, is the UHC for that inclusive and sustainable growth. So this inclusiveness is also very important, because we really emphasize the inclusion and the greater involvement of communities, civil societies, etc., not only government, not only UN, but these societies, and also private sectors. This private partnership and civil society involvement, very, very important, but we need mechanisms to involve those kind of people. Second, it is health system strengthening. Actually, recent round of a Global Fund provide more than 30% of the grant to that 6 building blocks of HSS, very broader aspect of health system strengthening, especially for that the health management information system. We are now working on that AP data and subnational kind of hotspot identification, and also the subpopulations. So identifying that epidemiology, that hotspot, very, very important to maximize our limited resources. So we also need to utilize that one for NCD and other fields. And also measurement, we are kind of performance-based financing. So measurement is also very important. As I said, we are now reducing the burden of countries for reporting and shifting from that process indicators to impact indicators. And also procurement and supply chain management. This is very, very important, and we are also stressing. Even this, procurement supply management is a bit kind of fragmented in the countries. So we are working together with the UNICEF and others, to support this one. And we also try to make a kind of market shaping and dynamics to maximize that availability and affordability. And we are now putting, that procurement, etc. We are now trying to make a good the mechanisms. And third one is the human resource development. As you know, that we have a lot of training, but very much fragmented. So we really need to work with World Bank and others to make a better strategy and action plan, very much integrated way. And okay, third one is a planning and national strategic plan. Actually, we are we are now moving toward the new funding model, more stressing that country ownership and also dialogue-based grant, and focusing that high-impact interventions in countries, etc. But anyway, we are supporting, together with other partners, that developing the robust national strategy plan, and also strengthening the alignment between the national strategy and the disease-specific one. And this one is the kind of important one. As Lori said, we have a lot of kind of fragmented and silo type of funding. So at this moment of planning, that nation really need to make a very good, robust strategy, national strategy, very comprehensive one, and making a better kind of alignment with a very disease-specific the costing, the costing and the national strategy plan, so that the different type of financing can provide a better the targeting and financing. And we're also supporting the kind of a counterpart financing and the sustainability plan. This is also why we need a partnership with the World Bank and WHO and others to support countries for graduation. But at the same time, we need to utilize our funding for catalytic the purpose. Because some of the countries, even they have good, ability to pay, but sometimes they miss some of the populations or, stigmatization, etc. So we have to utilize that money for as a catalytic to, facilitate some of the programs. Okay, maybe I better to stop because, I will really spend time. Thank you.
Now, next we have the pleasure of having a presentation by the representative of UPRO. Dr. Shin Yong-soo, please, you have the floor.
Thank you. I'd like to join with our colleagues in this roundtable to extend our appreciations that Japanese government and World Bank are inviting us and then have this important meeting. WHO's role in contributing to UHC, I think this is some basics, but I think UHC is not new to WHO, I must say, first of all. WHO was when founded in 1948, the aspiration of attaining UHC was enshrined in WHO constitutions. And in the Armata, the creation of Armata in 1978, the Health for All and clearly outlined the principle and value of UHC. And recent developments in these UHC issues, I believe, is a continuation of the effort. But I think this is very, very important momentum that we really need political support, and in country as well as global. I think when we have in this UHC in the first MDG agenda from 2015, then I think we will have a quite different dimension. We will have I think this really driving force being exploited. The WHO in Western Pacific region, where I'm reading, support 37 countries and areas as one of 6 WHO regions in the worldwide. The WHO's operating is highly decentralized, with each region directly supporting its member states based on the standard guideline developed by the WHO headquarters in Geneva. The real impact of UHC is at the country level. Each country has a unique context, and consequently, as I mentioned in previous session, the approaches for achieving UHC in each country should be different. This is why we help national government, not just the Minister of Health, but all key players related to health, to tailor the strategies, implementation plans, and monitoring frameworks which fit in each country's own situation. Key message from this conference, yes, of course, we already all agreed that this is a very much a timely event. Japan's experience and lessons learned from achieving UHC, particularly and simultaneously addressing the controlling cost, offering financial protections, and ensuring equity, provides a guidance as all our organizations strive to better facilitate implementation of UHC in our member states. Japan's experience are also of great benefit to other countries in their quest for UHCs. Japan made an early commitment to universal health coverage, and its people already enjoyed compulsory insurance for all people for more than half a century. Japan's highly developed health system has not only contributed greatly to the enviable life expectancy of the citizen, but also enhanced national social political stability and played a fundamental role in economic development. Developing countries can benefit greatly from close scrutiny, as we already discussed a lot, of the entire process of UHC development in Japan. Collaboration between the government of Japan and World Bank. Japan has positioned UHC at the heart of its strategy on global health diplomacy and exemplary effort to advance human security. Helping other countries by supporting the global UHC agenda is highly commendable. We appreciate Japan's leadership in this regard, and WHO in Western Pacific region. Japan, as its member for long years, and most important, and leading members in long years, to work more closely with the Japanese government in our shared endeavor to strengthen health systems and accelerating progress toward the UHC. We deeply appreciate new leadership at World Bank has expressed a deep commitment to UHC. World Bank is a major funding agency to invest in UHCs. We have been working closely with World Bank on measuring the progress of UHC at the regional global levels. We at the WHO intend to strengthen collaboration with the World Bank at the regional and the country levels. We complement each other well in taking the multi-sectoral approaches, and our shared interest in service delivery will further advance UHC in the countries. Thank you.
Thank you very much. Now, I'd like to group together presentations of similar organizations. And now that we have had a presentation of the UPRO, I would like to now turn to, not necessarily respecting the seating order, I would like to turn to PAHO, perhaps, Dr. Luis, to make a presentation, and then I'll turn to UNFPA later.
Thank you very much for this invitation. I'm sitting here for Dr. Carissa Etienne, our director, our regional director, who sent her regards. She couldn't make it here. As many of you know, she is one of the champions on universal health coverage. So PAHO is fully committed with the universal health coverage. It actually is our main goal for the next 10 years. We do have some very specific questions for our region, as you saw during the presentations, and our colleague from Peru here made many times this assertion about the social determinants of health. This is a very important point for our region. Actually, as you know, the global conference was held in Rio in 2011, and we have that declaration, and we are making universal health coverage, but also considering the social determinants of health as an important point on that. And reassembling what Dr. Chin already said, the alma ata inspirational of universal health coverage. So that would be a very important point for us at PAHO, particularly with the region of the Americas. The second point is PAHO particularly have a resolution from the countries about human security and health. And we see universal health coverage as an essential point for human security, both ways. Same thing, human security is needed for universal health coverage. So that's another point for PAHO. It's very specific, and we do need to deal with that when we do the universal health coverage alliances and movements in the region. Finally, we have this good alliance with the World Bank. It's a long tradition of work between PAHO and the World Bank, particularly in issues that regarding equity and healthy equity. And that's something we are working now with our colleagues in the World Bank. We have this very special time where Tim Evans is there, and we have worked with him very much by the time he was in WHO. Dr. Etienne is a good friend of him, so I think we have a very good environment to work together in the region to implement the universal health coverage. Thank you very much.
Thank you very much for your very concise statement. Now, I'd like to thank Mr. Bruce for waiting, and I'd like to turn the floor to you.
So we're still with the multilaterals. Good afternoon. I'd like to join others to really say a big thank you to Japan for hosting us, and to the World Bank as well for engaging us in what's been a truly exciting 2 days. And just very briefly to answer the two questions, we have a long-standing relationship with the government of Japan, who's been one of our most generous contributors bilaterally to the United Nations Population Fund, 11 consecutive years in the 80s as the top donor, and highly, highly appreciated. But on a technical level, we've had tremendous exchange on the issue of aging, launched the World Aging Report in October of 2012, received incredibly high coverage. And our relationship with the World Bank has a long history at country level, and we're really happy. I'm glad you're here, Dr. Ajay and Trina and others. We've just recently engaged in West Africa on an issue that will address reproductive, maternal, neonatal, and child health, as well as the demographic dividend, and looking at gender-based violence and a number of other very important issues. That's in a nutshell what we're doing with the bank and the government of Japan. However, we're also at a crux right now as UNFPA. We've just completed a 20-year review of the ICPD plan of action that was, as you probably know, launched in 1994. We had 5 regional meetings. We had 3 thematic meetings. And many, many of the issues that we've identified in terms of both the strengths and weaknesses of the investments that have been made over the last 20 years have to do with success and failure in relation to universal health coverage. As you may know, we had already committed to universal access to sexual reproductive health services at that time. And we have achievements, but if we look at MDG 5 in relation to the other 7 MDGs and also in relation to 4 and 6, it is the weaker link in the chain. And why? As we all know, it has to do with 24/7 access to some quite sophisticated services. It has to do with roads and communication and reaching the health facility, and it has to do with a tremendous amount of cultural and community level traditions and norms. So it's one of the more challenging goals that we had to address. So we look to universal health care to redefine how to go forward based on these lessons. And if there's one message we'd like to be integrated in the discussions today, if we had the vision and we had the crystal ball and we could look at 2030, what would universal health care really look like if it were to succeed? And I think our message is fairly simple. Although we've talked a lot about aging, it's really tomorrow is today, age 10, and it's a girl. And we noted yesterday the lack of discussion on gender. We did discuss it later on equity, but it's a girl, and it's a 10-year-old girl. And our success would mean when she reaches the age of 25, throughout those 15 years, she would have had access to resources, to information and services to maintain her dignity, to maintain her rights, to be the fullest potential human being that she can be. She would have not married before choosing to do so. She would have not engaged in sexual activity before choosing to do so. She would have chosen when, how many, and even if to have children at all. And that's not the case today. 7.2 million girls gave birth to children under age 18 this year, 2 million under 14. We have a long ways to go. So when we think of universal health coverage, we want to make sure that it meets and treats with fullest respect that 10-year-old girl. That's the perspective that we have as we're looking forward into the universal health coverage within the context of the post-2015 agenda. Thanks.
Okay, now we have had the presentations of international organizations, and we now turn to presentations of representative civil society organizations. And first, I'd like to turn the microphone over to Ms. Ishii of JCIE.
Thank you, Chair. I'm Sumie Ishii, JCIE, Japanese Organization for International Cooperation in Family Planning. I'm also, together with Ariel, is a member of World Bank Health, Nutrition, Population, CSO Consultative Group members. And also, I'm a facilitator of the regular dialogue between more than 40 CSO and Ministry of Foreign Affairs of Japan, which has been organized bi-monthly since 1994, which we are a little bit proud of, after the ICPD Cairo conference. So here I would like to mention 2 things. One is CSO's role at local country level, and 2, the request to Japanese government and World Bank. So for the CSO's role at the local and country level, though everything had been said, I would like to point out 3 roles. CSO as advocator, implementing partner, and watchdog. One as advocator has influenced the government, both Ministry of Finance and Ministry of Health, and donors to make investment in universal health coverage, while for community and community people, I think CSO can work at the sensitization of universal health coverage. Unfortunately, people do not necessarily trust the government policies and services, which quite often happen. And then the second part is implementing partner. Decision of universal health coverage tend to focus removal of user fee, but quality of services as well need to be further discussed. In this regard, CSO as an implementing partner can play a crucial role to achieve strengthened quality primary health care at the community level through community health system strengthening. Even my limited experience, I witnessed in several countries underutilization of health facilities. By the end of the day, what community people need is quality of health services provided by qualified, well-trained health staff and regular supply of medicine, hopefully in one place. The third is watchdog role. We hold the government and donors accountable through policy dialogue, monitoring the budget spending. So in here, I don't think that it's further necessary to further emphasize the importance of geo-NGO partnership. So the second point is the request to Japanese government and World Bank. We CSO welcome and support the leadership taken by the government of Japan and World Bank and WHO on universal health coverage. For the government of Japan, we would like to request to keep up this leadership and advocate universal health coverage in the post-2015 development framework. Also, please continue to share Japan's experience, not only social health insurance, but also the recent Japan's health movement, such as Healthy Japan 21, or under this coverage, we have Healthy Mothers and Children 21 that have been promoting as a movement inclusive effort. For the World Bank, we expect to be both the hub of knowledge and information on universal health coverage, as well as negotiate and convince government, including pushing the government back to organize Ministry of Finance and Health dialogue. Attainment of universal health coverage, we believe, is a powerful means to achieve World Bank Group's new goals by 2030, end extreme poverty, and promote shared prosperity. Thank you.
Thank you very much. Now I'd like to invite, last but not least, a representative of the CSO organization from Peru, Dr. Ariel Frisanto, CARE Peru. You have the floor.
Thank you very much. Honorable Ms. Sherry Aiti, Minister of Health of Ghana, stressed the fact that health is not a commodity, it's a human rights, and asked about our approach. We want to invite you to analyze what human rights components and right-based approaches could provide to a vision of a more integral universal health coverage. We do believe that right-based approaches, principles, standards, and indicators provide meaningful contents to enrich and extend universal health coverage priorities in a way they could get better health outcomes and also construct more responsive health systems to people's needs and expectations. Actually, right-based approaches principles give us lenses that help us to give the same weight to both financial and health delivery issues. They help us to identify a first alert. As Professor Isao said today, universal health coverage cannot be understood solely as universal health insurance. When we do so, we could end with some collectives of people that are just registered in a system that doesn't guarantee effective access nor necessarily quality and rights respect. Right-based approaches also take us our attention to the social determinants of health, because as we know, human rights are not only about available, accessible, acceptable, and quality good health services, but to the right to live in healthy conditions, to live with dignity. And we need to address that if we want that healthcare, which is just one of the social determinants, succeed in its purpose. Actually, in regions like Latin America, with the vast disparity that they have within the countries, this is a key issue. It's also a tool, right-based approaches are also a tool that help us to identify from the eyes and livings of the patients themselves how we could construct the health system in a way it could better answer their needs. It calls our attention, for example, to the issue of human resources policies. We then talked sometimes about what we used to call the schizophrenia of the medical doctor, that in the morning in the public hospital could be not so interested, sometimes indifferent to people's needs, but in the afternoon in his private consultancy is a treaty of quality. So it's not only a matter of training, it's also a matter of good incentives for the good and negative for the bad, so we could improve performance and have people saying, some saying about that performance. It has, as a key component, the issue of citizen participation and accountability. And I think yesterday in the technical meeting and today, we tried to raise this issue and the importance of this issue to get people more involved in what is going to be decisive for their lives. If we don't listen to the people, we can't orient the services to their expectations. And here comes a second alert to all the officers. Avoid the risk of entering in a technical autism in which we only find solutions amongst them ourselves and get little contact with the reality, that means with the people's feelings and needs. That's a key issue for us. It has to deal also with discrimination, and we don't talk only about face-to-face discrimination, but also the discrimination of policy making when we know who are the most in need, and sometimes, because of many reasons, maybe even political weight, those collectives of people don't receive all the resources, all the knowledge that we could provide to them. So, to finish, based on your context and your health system history, right-based approaches provide you with the ingredients to enrich universal health coverage. Having said that, we have to bear in mind that these are not ingredients we could disregard, as they are human rights mandates for which the governments are accountable to their societies. And now we have an opportunity in the global community, thanks to the United Nations Secretary General initiative on accountability on maternal and child health, but also thanks to the Human Rights Office, High Commissioner of Human Rights Office, that has just launched a technical guidance on how to implement right-based approaches towards maternal health and child health. At the end of the day, what people is expecting and increasingly claiming are the same attributes of availability, accessibility, not only financial, acceptability and quality that any one of us would expect for ourselves or the person we love the most whenever coming into contact with a health facility. And whatever is necessary for enabling people to live lives with dignity. As civil society representatives, it's our own mandate to always remember this. Avoid the risk of technical autism, together with the massive efforts governments are making towards achieving integral universal health care coverage. It is time to re-listen or to listen our people. To listen and to act accordingly. Thank you very much indeed.
Thank you very much, all the panelists, and thank you very much to you for the patience. The Secretariat has informed me that His Excellency Mr. Minister of Health, Labor and Welfare will be here shortly for his final concluding remarks, and we only have 5 minutes to go for questions and answers. So I'd like to invite maybe 1 or 2 or maximum 3 short and concise interventions. Yes, I have one hand being raised here and another. Are there any other questions or comments? No? Okay, good. Then please, therefore, you have the floor. Yes, please.
Thank you, Mr. Chairman. First of all, I have to say that I'm very much impressed with the level and the quality of the discussions of all the panelists, and I am particularly intrigued by the comment made by representative from, I understand, Rockefeller Foundation, Mr. Mark Chuak, or yes, I think I cannot remember exact word he used, but he said to the effect that sometimes at the country level, the people do not know whether the most optimal option, policy option was adopted, either because policymakers do not know what the options are available, or maybe they knew what the options are available, but because of the political environment, they adopted so-called easy way out. They don't know. I think this is a very important observations. And based upon my past experience with working for WHO for many years, if I put it very bluntly, at many countries, people do not have a capacity to make a judgment as to whether the option A or option B is the case for the country. That's why this is a comment or my suggestion, because all the partner agencies are here. My plea or question is that all the partner agencies present here are ready to provide technical support so that the member states, particularly with the limited resources, can obtain the capacity building so that they can start with the ball rolling as to whether what is the major hindrance to analyze the current situation. Mr. President, thank you very much for this follow-up.
Would you like to make a brief response to that, perhaps?
Very brief. Yes. Okay. If I respond, I'll probably just say what I said already, but why don't I say what I said already? I think I think it's a very important point. I think what I was trying to say is that no two situations are alike. This is where having kind of a donor program or approach that cuts across the world may get us into some trouble. Because there are very different situations. There are cases, and I certainly can say many people I've worked with, who have a very good understanding of the options that are on the table for them, some very, very good technocrats in countries I've worked in, but they will also tell you in moments of candor that they have some severe limitations in terms of their scope of action, often from politicians, from other interests in society, or simply financing problems, and that their approach is that the perfect is the enemy of the good, and that doing something suboptimal is better than doing nothing. Now, you could argue that that's not better than doing nothing, that it's better to wait and do the right thing. I'm not taking a position. I'm merely saying that this really is a serious question, and that there sometimes is an embedded assumption that people simply don't know, and that's why they're making bad choices. And I'm suggesting that sometimes people do know, and they're making choices based on other considerations or criteria, and that the nature of donor assistance has to be tailored to that.
Now, I think it's almost time to conclude this final policy roundtable. So if, with your permission, I'd like to cite some points that caught my attention. Maybe all the presentations emphasize the centrality of universal health coverage toward the post-2015 agenda. And I think they were almost unanimous in emphasizing the centrality of this issue. And secondly, maybe the efforts toward universal health coverage requires a comprehensive approach, but a comprehensive approach might take different forms in different contexts. And different development partners have different advantages and strengths and with which they can contribute to the efforts of partner countries. And thirdly, perhaps as we discussed in the last session, we have to come to a broad understanding that both the financial risk protection coverage as well as the health services coverages, both are very important. And finally, somebody in their presentations emphasized the importance of learning. And I think this two-day conference has been a tremendous opportunity for us to start or to continue mutual learning. But this is not the end of our process of mutual learning. As Mr. Aso emphasized in his introductory remark this morning, the World Bank and Japan planning to organize what we call flagship course for the knowledge sharing and experience sharing among practitioners. And this kind of learning process will facilitate the mutual understanding between practitioners and policymakers. And finally, though I'm not in a position to represent the Japanese government as a Japanese development practitioner, I'd like to thank all the kind remarks that you made about Japan's commitment to universal health coverage. As a development practitioner of Japan, I'm very happy to hear those kind remarks, and we're very committed to continue these efforts toward the achievement of universal health coverage. Now, with these remarks, I'd like to conclude this Development Agency Roundtable, and I'd like you to join me in thanking the panelists for their presentation. Thank you.
Well, thank